Thank you very much. Thank you for inviting me, and actually it's deja vu because the prior speakers like Yabut and Wellington were my group mates, and nothing has changed. I remember those times like during presentations, right, Chris? You'll sit there and listen and listen and listen. Anyway, it's good to see old group mates back. Okay, so there's a lot of segue that the prior speakers have already done, and I think it's a common theme we keep on talking about cardiovascular risk factors, obesity. So mine actually is more focused on children because I'm a pediatric pulmonologist and sleep specialist. I have no disclosures except that I am a proud member of the UPCM 19. And so our objectives will explain the interaction of obesity and sleep disorder breathing in activating the inflammatory pathway. We'll identify the metabolic alterations and complications of this inflammatory pathway, and we'll discuss potential targets. So if you grow up to be half the man your father is, that would be good. So the prevalence of OSA or obstructive sleep apnea in the US is increasing due to the rising rates of obesity. So there's a lot of sleep apnea because there's a lot of obesity. So I wish it's that simple. So in adults, we usually see this phenotype, like it's usually a kind of heavy-set man with a large neck circumference and a normal Mallampati score. And Mallampati score is when you ask a person to open his or her mouth, and if you see the entire posterior pharynx and you see the uvula, then that's a Mallampati of 1. And then you progress to 2, 3, 4, and you can see on the Mallampati of 4, you hardly see the posterior pharynx. So you can just imagine that there's a lot of vibration during sleep, and that's typically observed. So there is more into that story, though. It's not just because of fat. Like the sample of a fat man. I'm talking about Hannah. Doesn't mean that that's the only reason for obesity. So there's quite complex interactions. So in children, though, the typical phenotype is that the tonsils, peak in size at the age of 2 to 6 years of age. So that's usually that if you are grown or at risk of having sleep apnea, that's the time that you usually understand. And usually have nasal congestion, mouth breathing, and we have that look, that adequate fashion look. So again, we wish it's simple that we just take out the tonsils and adequate. But we know, and it's a common theme, I kept on listening to prior speakers, there's really emergence of an epidemic of obesity. So in adults, what's the prevalence of obesity in adults in the US? Any guess?
42.
So I hear 40, 45, we're actually close. More than a third of people in the US, based on the NP study, are obese, and that equates to 78.6 million people. And we know that class 3 obesity with a BMI greater than 40, this is referred to as morbid obesity or severe obesity, 6.3%, so close to 10% of the population. And in prior talks, we know that there's a lot of health hazards. The classification actually of BMI is based on the risk of cardiovascular risk factors. Right, Dr. Wellington? Okay. And, this is a worldwide concern because when I look, the number of obese Filipinos rose from about 15% in 1993, so only 2 decades ago, to 31% in 2013. So it kind of doubled. And in children, the prevalence of obesity in children and adolescents aged 2 to 19 years? What's the guess?
62.7%.
70%. That actually amounts to 12
Black America.
million. Well, it depends also on what geographic area you are, right? And there's racial and age disparities of that. But you can see that Hispanics and the non-Hispanic Black youth better? Yes. Okay, so Hispanics and non-Hispanic Black youths are actually more at risk for obesity for a number of factors as compared to white youth and Asian youth. And when we talk about sleep disorder, breathing is a spectrum. So the bulk will be obstructive sleep apnea, but we also have mixed apnea, central apnea, obstructive hypopnea. In children, actually, we check their CO2 levels, because sometimes they don't have the overt obstructive apnea, but just hypoventilation. And then another, the milder end of the spectrum that also correlates with inflammation is upper airway resistance syndrome, where you just have respiratory vent-related episodes. So this is not linear. It's not just that the treatment is weight loss and then there's resolution of OSA. So a very good kind of diagram to discuss is this hypothetical interaction of OSA and obesity. So if we look at the first box, which is concentrating on obstructive sleep apnea, you know that it's associated with sleep fragmentation and intermittent desaturations. So what would happen is there would be neurohormonal changes as well as oxidative stress. And both of them would lead to the pathway of inflammation, and the endpoint would be production of all of your pro-inflammatory markers. Now, in the obesity side, you can see that it also plays into the inflammatory markers. And so, you know, they augment each other with the presence of both obesity and obstructive sleep apnea. So what is the context of all of this? Well, the question is why do we sleep? Judge, why do we sleep? Because we want to. So to rest, to restore exhausted brain metabolism. So actually that's a very limited view because there's a complex process that occur in the sleeping brain. That's why I think a number of sleep specialists, they're not just pulmonologists now, but neurologists, because they see the importance of sleeping daytime functioning. And this is very interesting. The next 4 slides will emphasize why you need good sleep. So, with altered sleep, it can cause cancer. Weight gain, inflammation, depression, harder to control emotions, harder to read other people's emotions and relationships, weakens the immune system, increases the risk of diabetes, it's just like that. It permanently damages your skin. It makes your brain dirty because sleep promotes removal of neural waste from the brain. It increases life expectancy, so we want to live longer. Reduces the effects of vaccines. Increases the risk of heart disease, and it tricks you because you're judging your effectiveness of basic tasks. You think you're effective, but you're not. Actually, yesterday I was like, I just came from a 24-hour flight, and it's like unpacking, and it really affects your daytime functioning. Right, Helen? Then Helen had to work after a long 24-hour flight. And with altered sleep, these are all the obvious ones that we have discussed: increases blood pressure, irregular heartbeats, increases the risk of stroke, make you weaker because it affects your muscle mass, destroys your bones because the bone cannot repair itself, and increases chronic pain. And there's more. Increases the ability to cope with stress, increases the ability to respond under pressure, so panic, making rush decisions. It kills your creativity. It increases the risk in dying from a car accident and causes renal. Tulog na daw. So, why do we sleep? Because it actually contributes significantly to learning and memory. So, neuroplasticity, where you develop a lot of networks, consolidate, all the information that you gathered, whether it's behavioral, environmental, technical emotions, and recovery. So there's various areas in the brain, but particularly hippocampus, the temporal lobes, and the neurocortical areas. So why am I talking all of this if my talk is inflammation and obesity? So we know that sleep may be a privileged time window because you're free from interference from external sensory inputs and allows your brain to recover. I'm not touching it.
Yes.
Okay, so we will.
Diabot.
Okay, this is okay? Yeah. Okay. So the pro-inflammatory effects of sleep, it compromises immune function because there's increased cytokine secretion. So these are all the studies that I'm going to cite about. That's the correlation of this with sleep deprived in children. Okay, so now I will talk about all the 4 slides of recent deprived sleep. So the hormones affected. In weight gain, it's leptin and ghrelin. For inflammation, cytokines. For all the depression and emotions, it's your serotonin. Remember, serotonin is related to one neurochemical in sleep. Melatonin. That's why we use melatonin a lot as a sleeping aid. It's in the same pathway. And then again, immune system, the cytokines, risk of diabetes, insulin, permanently damages your sleep because it affects the cortisol. And then more cytokines and catecholamines for blood pressure and cardiovascular. And more of the cardiovascular for cardiologists here. Growth hormone, we know that the production will be increased during sleep. And pain again, serotonin levels. Okay. So fight and flight. So what happens is that if you're sleeping when you're okay, but if there's an interruption of your normal sleep architecture, there's also alterations in your physiology. So imagine if you have obstructive sleep apnea, you have ups and downs of your O2, and there's also episodic hypercapnia, so you have relatively higher CO2 levels. There's occlusion of the upper airway, so there's large kind of changes in your intrathoracic pressure, and it causes recurrent brain arousals. And so it induces potent and sustained activation of your sympathetic nervous system. So the time that you should be resting, then you're kind of active. Okay. So example of fight and flight. So we have the flight from Hong Kong, from Seoul, Korea, Beauty and the Deer on Headlights, and flight from Narita. Actually, a lot of people came from Narita. And this one actually is beyond the scope of the talk today because this is alcoholism or consumption. And somebody's excited. The first stop was a jolly. So what happens when your sympathetic nervous system is activated? So imagine stress hormones are really very important. Like for example, a good stress is exercise. So when you're exercising, your breathing rate increases, your blood flow to the skeletal muscles, and then everything kind of slows down as far as your gut is concerned. But imagine stress hormones during sleep. Okay, so it's the same hormones that you're activating. That's why the end result or the complication of your sleep apnea will be what? Hypertension, right? Diabetes. What else? Cardiovascular, right? So just imagine those 4 slides of the effects of altered sleep. So those are the main effects because you are on a fight and flight mode. So now in terms of liabilities, you have neurocognitive and behavioral disturbances. I want to share this specifically because in children, there's a lot of link with poor sleep and hyperactivity, or poor sleep and poor cognitive function. And actually, David Bozal is one of the big researchers in children and sleep apnea. And one of the interesting studies that he did is, it's a very simple study. When he was in Tulane, Louisiana, he went to the public school system and kind of looked at all the kids, the low-performing kids, looked at their airway, and those with big tonsils and adenoids, he offered to the parents tonsils and tonsillectomy and adenoidectomy. So for those who consented, so he followed in his control group or the parents who didn't consent. The following year, those who had tonsillectomy and adenoidectomy fared much better and improved their academic performance. But those who did not have tonsils and adenoids remained at the lower part of the class. And after that, he published several articles. And in terms of cardiovascular morbidity, there's both systemic and pulmonary hypertension, it's myocardial and endothelial dysfunction. It's very similar, actually, to the studies that have been seen in adults. So the short-term and long-term implications of OSAS could be amplified with the concurrent presence of your obesity. So this is actually very interesting to me because it doesn't seem kind of intuitive that you connect neurohormonal changes with that of the inflammatory pathway. But the key determinant in the development of your neurocognitive function is actually related to the magnitude of the inflammatory response. And one of the interesting things that they look at in cognitive function is C-reactive protein. Remember, C-reactive protein is a measure of inflammation. So they looked at about 300 children, 5 to 7 years of age, and that's both snoring and non-snoring children. And they did a sleep study, neurocognitive testing, and a blood draw. And so this is the summary of it. So out of the close to 300 children, those who are snorers, the OSA children look at their mean CRP. It's relatively higher as compared to the non-OSA children. And for those who have OSA, when they did this is the point. When they did cognitive testing, those who have an abnormal cognitive test have a way higher CRP than those with normal. So that's very interesting how they were able to kind of correlate sleep problems and CRP level. Okay, and in children also, for those with big tonsils and adenoids, we know that it reduces the patency of the airway, and that leads to pharyngeal resistance and episodic collapse, like what I described earlier. But in children, we just don't think of big tonsils and adenoids because there's other risk factors like obesity or craniofacial abnormalities or neuromuscular abnormalities that contribute to the risk of OSA. But interestingly, when they actually look at tissues from the tonsils and adenoids of patients from OSA, they have increased expression of the pro-inflammatory markers. When they compare it to the tissues of children, they just had surgery, for example, for recurrent tonsillitis. And why is that? How would you explain that? It might be that the recurrent vibration in the airway would promote localized inflammation. So with this, you have swelling and overexpression of your cytokines. And another study that they did is when they measured the breath condensate and sputum of children with OSA, there's an upregulation of these inflammatory markers. So in terms of the emerging epidemic of obesity, in Western countries, particularly the prevalence, is a range of, in America, in the US, it's one of the highest. And each increase in 1 kilogram per meter squared of your BMI above the mean in children, your risk of OSA increases by 12%. And corollary to that, actually, when you have sleep restrictions, so if you have poor sleep, it correlates to the increase in your BMI. So sometimes the question is the chicken or the egg? Like, because you're obese, you're at risk for OSA. But really, if you were not sleeping well, then you tend to lose weight. So with the changing kind of landscape with the epidemic of obesity, there's now a proposal that there's really 2 types of OSA in children. So it's like comparing it or an analogy to type 1 and type 2 diabetes. The type 1 are the children with just big tonsils and adenoids. But the type 2 are the obese children in the adolescents. Especially in America, we have a lot of obese adolescents who are showing manifestations of metabolic syndrome already. And the concern is that the next generation, the lifespan will be compared to the present life. Okay. So what happens to children with persistent OSA? So children who had tonsils and adenoids but still would have persistent obstructive sleep apnea. So after 5 years, they are at increased risk of developing obesity. And in bigger children or in obese children, the amount of tonsils and adenoids that they have to have sleep apnea is actually smaller. So it doesn't take big tonsils for them to have OSA. And the obesity-induced OSA behaves differently from the OSA phenotype that is exclusively just from big tonsils and adenoids. So obesity in children is really a multi-systemic disease, and we find that there are a number of psychological disturbances like depression, suicide risk, and poor peer relationships. So now there's an interest of having this multidisciplinary approach to obese children. And our GI colleagues actually are also very busy because there's a number of complications like GERD and fatty liver or irritable bowel syndrome that they see. And in terms of the metabolic syndrome or insulin resistance that we have discussed in adults, although it's only 4% in adolescents, the prevalence actually increased to 30 to 50% in overweight and obese children. So there's a significant increase in the prevalence of childhood type 2 diabetes. Actually, any endocrinologist locally, is there an increasing rate of type 2 diabetes also in the Philippines? And so the risk for that would be early onset of cardiovascular disease. And in the US now, there's kind of a recent update that there's one in every 3 children who have a chance of developing type 2 diabetes. So that's a lot. That's like 30% of all children. So how many of you are familiar with NHANES? So the NHANES is actually a big national survey. I'm up to my 10th line. You want me to make this? survey of health factors in the U.S. And obesity is really considered as a chronic state of low-grade systemic inflammation. BMI, or body mass index, was the best predictor for elevated CRP. So now let's go to lipid and metabolic profiles. Raymond have talked about, cholesterol and triglycerides. So specifically in children, this study involved 62 children with sleep studies, and they have significant associations with sleep disordered breathing and that of your triglyceride and cholesterol and LDL, HDL ratio. So when you treat OSA, just simply treating OSA, it resulted in significant reduction in your LDL and all of the other bad guys as far as your triglyceride factors are concerned, and insulin sensitivity improved in these children. So there's really a role of OSA in lipid balance and the type of treatment of OSA. So how many of you have heard about leptin and ghrelin? Okay, so Raymond, thank you for kind of introducing that. And leptin and ghrelin is really the yin and the yang thing as far as us feeling hungry or satisfied or satiety. And leptin is a mediator of long-term regulation of energy balance. So it suppresses your food intake and induces weight loss. So when you stop eating. Ghrelin is a fast-acting hormone, and when you're hungry, it's activated. It's role in your meal initiation. So in obese subjects, the hormone leptin is increased, so you don't want to eat anymore, and the hormone ghrelin is decreased. But in established obese patients, they become leptin resistant. So leptin actually is found in the white adipose tissue, and apart from its role in hunger and satiety, it has an important modulatory role. So leptin stimulates the production of all of these pro-inflammatory cytokines, and it's typically elevated in obesity. So leptin is the bad guy because it promotes systemic inflammation. And so now looking at the epidemic of obesity and sleep deprivation in society, we have a lot of demands of change in diet. You're looking at potential targets of leptin and ghrelin relationship in the treatment of OSA and obesity. And in adults, you know that there's elevated circulating levels of leptin. And if you address OSA, then the leptin levels will be reduced. In children, this is an interesting study. There's increased levels in OSA that remain significant even after adjusting the degree of obesity in sleep patients. Tumor necrosis factor, we talk usually about TNF in cardiology or in oncology, but now it's in the realm of sleep. It's a pro-inflammatory cytokine, and it promotes cellular adhesion. So when you talk about adhesion, you talk about what? What risk factors? Stroke, right, blood flow. And again, the production of your TNF-alpha correlate with the severity of your daytime sleepiness and your degree of hypoxia. So again, in children, they look at TNF levels and they correlate again with OSA. So this is the summary of what I just shared you. There's obesity and OSA with all of their different pathways. The common pathway would really be increased inflammation and oxidative stress. And the bottom line is you have risk factors for your metabolic syndrome here, and also your risk of stroke and cardiovascular disease, which what we talk about in detail this morning with prior speakers. So the message being that I'm a pediatrician, the onset of cardiovascular disease in the context of obesity and OSA actually begins very early in life. And so the true impact of that would be your inflammatory and your cardiovascular alterations in adulthood. So it's time, it's urgent. We need to recognize that even in the pediatric world. So there's really complexity of these interactions. We heard about lifestyle modification earlier, and I think that's one of the message. And we really want that to be a single multifactorial model. So like the organizers of this talk or CME actually kind of gel it all together because I think it's all. And thank you.